With femoral acetabular impingement, one of the main things that we are focusing on as PTs is helping people train around this either formal or informal diagnosis. So for people that need to get into deeper positions of hip mobility, to either weightlift, to achieve fitness, or potentially for their sport, we need to make sure that we're communicating to them certain things that they may want to be thinking about while preparing for whatever activity that they are actually doing. So, Zach, where would you start, say, for a weightlifting population?
Yeah, so there's 3 buckets in this kind of intermediate phase of rehab that we're talking about. So we've had our eval, we've got them on a home program, we've talked about self-care for symptomology, we've got them on probably a couple just very entry-level strength or stability activities. Now that we're moving into kind of the meat and potatoes of the programming, there's 3 buckets that you really want to hit. One is going to be more of your replicating whatever that provocative task is that they're trying to get back to and finding a way for them to maintain participation with it, but potentially in a modified environment. So say somebody has pain with deep squatting, cool, maybe we can't barbell back squat, but we can still do that squatting movement pattern, and maybe we either do something from a weight displacement to modify. So maybe instead of going a back squat, we're doing a front squat, maybe we're going safety bar, maybe we're going goblet squat. So maybe just repositioning of where the load is placed allows them to get a little bit more depth or just a little bit more comfort with whatever depth they have. Maybe we're propping heels, maybe we're doing something to narrow or widen the stance, but something to try to replicate whatever that main terminal task is that they're trying to get back to. I like to do that early on too, because that's your reference point for success. And with that, you're really taking a few modifications and you're introducing them early, and then to get back to whatever that terminal task is, you're just incrementally removing one of those modifications you gave them until they're back doing what they intended to do when they came in. So you're doing something to replicate the task at hand they're trying to get back to. Other things we need to do is just get them moving. So this is where I think about what does a good, well-balanced strength program look like for somebody if they didn't have any injury at all? And I think you go into the mindset of let's build out just a very good lower body and core strength training program. Then what you do is you look back at your eval and figure out, all right, which of these are they not going to tolerate well based on their symptom profile or their available range of motion and strength. And with those, I like to put kind of an asterisk around those. Those are the ones that you're putting into the modification category. All the other ones, you train as is. You maintain intensity, you maintain volume. And with this, things that I think about are, say they're very hip flexion is the area of influence or the area that's problematic for them, and they can't tolerate some of those deeper sagittal plane activities. Maybe that's where we're bumping up some of our frontal or transverse planes. Maybe like a lateral box squat is something that they can do well, which in this case, they may not with it being FAI, because that is going to replicate a lot of what the FAI areas of symptom provocation are, but just giving you a reference of an example of where maybe they can't tolerate a regular squat, but a lateral box squat would be something for them. Maybe you need to modify to where they're going a little bit more split stance, or maybe they're going into some of their single leg activities, or maybe you're modifying squatting for hinging patterns. But I always like to start with just building out a well-balanced strength program. Then you go through and you try to figure out which ones are going to be the ones they're most likely to not tolerate, kind of put those off to the side, and then you let them train as is with all of the other activities. The third piece of the puzzle is what can we do locally to that area to either gain strength in isolation or just tissue tolerance. So this is where maybe we're going for our hip flexor or our adductor complex, and we're looking at introduction of isometrics early. Then we're going into some eccentric loading. Then we're eventually going into our more traditional isotonics with that. This is also a population where maybe I'll give them more of your traditional entry-level PT School 101 type activities where we're talking about sideline leg raises for hip abduction. We're doing bridge variations. We're doing some sort of table work for hip rotation, whether it's clamshells or hip IR off the edge of the table, but we're complementing that with BFR. And that's an easy way to get some of those single joint, single plane, isolated movements that are going to allow them to really target the tissue at hand, meaning a lateral box squat's a frontal plane activity, but you can't quantify exactly how much glute med or how much gluteal or hip abduction force is happening. If you put them on their side and have them do the resisted side-lying leg lift, there's only one muscle group that's going to help with that. So that's the trade-off with exercise that I look at is when you get into more of those single plane, single joint tasks, you're always going to be limited with how much you can physically load them. You're always going to be limited with knowing how much that's really going to translate into a more multi-planar, multi-joint functional task. But I still think they serve a purpose in rehab. And in this population, that tends to be one where we're introducing very early, maybe in that first 1 or 2 sessions from a body awareness standpoint, and then you're supplementing it with BFR moving forward as you hit more of your well-balanced strength training program, and then your exercise modifications to whatever that irritable task is or that terminal task they're trying to get back to.